we're going to kick off. You're all very welcome to the first Reach event of 2026. My apologies for the slide. I see it on the 14th of January. It should be the 15th of January, so it's not a time warp. Just a few introductory remarks from me before we get started. This meeting is being recorded. You know that the kind of fundamental rationale here is a desire to meet an education and networking need for those of us who work outside major metropolitan areas, but also for those that work in major metropolitan areas and are interested in generalism particularly. So this network focuses on clinical generalism and interconnectedness, particularly between primary and secondary care. Some housekeeping. This is a virtual meeting, although we are planning an in-person meeting network event for later in the year, so exciting news there, and we'll keep you posted about that. The meeting is being recorded with Scott's consent, and we'll make that available to those who can't attend. The presentation will last for about 40 minutes, maybe 45 minutes. There's opportunities for questions, and I know Scott has made the presentation quite interactive, so there'll be some Mentimeter activity during the presentation to keep you on your toes. If you do have questions, please use the chat function. Myself and Michelle Canavan will keep an eye on that during the presentation. And if you are asking a question, we'd really appreciate if you could turn your camera on and interact, and welcome to keep your camera on during the presentation as well. Microphone's muted. The hospital buddy code for CPD is there. It's also in the chat. The ICGP CPD is approved, and you can apply through the website. If you do have any feedback for us or thoughts about future content, please get in touch with us at the network event, at the Reach Network email address. Also, the feedback form, we really appreciate your feedback. Any and all feedback is welcome, and we'll adapt what we do accordingly. Important to say, obviously, Scott's going to give us up-to-date information. He's making his best efforts to make sure it's accurate for today. But this is a talk that's given in good faith, and it doesn't replace clinical guidelines and should not be used as such. Before we proceed, I'd like to draw your attention to next month's speaker. Delighted to have my colleague and friend, Michelle Canavan, who's a professor of older adult health here in Galway. And we're going to move away from the clinical topics towards integrated care, a snappy title, The Good, the Bad and the Ugly. It's going to be a kind of a run through of integrated care, which is really critical intersection between primary and secondary care. So we think it should be of interest to folks, and we're really looking forward to that. So you might put that in your diary for the 19th of February, same time, and we'll send a reminder down the line. So to today's event, delighted to also welcome my colleague and friend, Dr. Scott Walkin, who's well known to many of you. He's a GP in Ballina. He also works with AMRIC and with the ICGP, and his title today is related to antimicrobial stewardship. Neart, chéile, there's no strength without unity. So I'll hand over to Scott and stop sharing, and thanks very much, Scott.
Thanks very much for the kind introduction, and hello everybody. It's really a pleasure to be here, I have to say. I'm going to hopefully be able to share my presentation. So Rob, I see you on my screen. Can you see that now?
I can see that, Scott, and we can hear you all working fine.
Lovely. Okay. So I call this There's No Strength Without Unity, because I think if we can all pull in the same direction when it comes to antimicrobial prescribing or not prescribing antibiotics, I think it sends clearer messages to our patients so that there isn't confusion about when they need to attend and when they don't need to attend. I am certainly conscious that different contexts require different levels of care. So not everything I will say is going to be applicable to the hospital context, particularly the inpatient hospital context. But I think it's right to say that in the outpatients and in the emergency department, that there will be a lot of overlap. Now, I'm very happy to be interrupted if it's okay with the chairs, to address any questions or to answer any questions. With regard to the chat, I won't be able to keep an eye on that while I'm speaking, but I'll certainly have a look at it intermittently, or if the chairs wish to.
We can jump in if there's anything major there, Scott, if that's useful.
That would be very helpful. Yeah, thanks for that, Michelle. All right. So I work as a GP in Mayo. I'm coming to you today actually from the Atlantic Technical University in Sligo, which is our new worldwide headquarters of GP training. I also work as the clinical lead for antimicrobial resistance and infection control with the Irish College of GPs. So they're my sources of income. I don't receive any income from pharmaceutical manufacturers or vaccine manufacturers or anything like that, or industry generally. So I'm going to try and make this a little bit interactive. So what I'd like you to do, and hopefully if you have an extra device, you'll be able to either scan that QR code on your screen at the moment, or alternatively go to menti.com and put in the code. And this will just allow for a little bit of interaction. But beyond the online interaction, if people want to ask questions, as I say, very happy to do that. So I'll give you just another moment or two to enter that. The code will be on the top of each slide that I have. So if people come later, there'll be no problem with joining menti.com. So I'll just leave that up for another few moments or another moment, and we'll move on. I see we've about 16 people have signed up onto that, and they're still increasing. So we'll move on. And if there's any difficulty, if people get kicked off that platform, they will be able to rejoin at menti.com using the code that's either at the top of the screen or on this screen that's on the left-hand side as well. Okay. So just a broad outline. Now, we may not get through all of this, but in the time that's available, we'll get as far as we can. So I want to talk a little bit, just a brief introduction about antibiotics. And then I want to talk about a thing called chest SSS. So I was looking for a Google image for this slide, and I put in chest SSS, and this was one of the more suitable for work versions pictures that came up. We'll talk about respiratory hacks, then some bite-sized dental nuggets, and if we get to it, urinary stream of consciousness and a thing called backup. At the end, there'll be just a very mini quiz. So what I'd like you to do is if going along, you identify something that might be of use to your clinical practice, to make a note of that, because at the end, I'm going to just ask people to try and summarize anything that they might have learned from this. Hopefully you will come away with something. So this is just a starter for 10. So how long do you think antibiotics have increased life expectancy by, roughly? And I acknowledge that if you look in different papers, you'll probably find different estimates. But maybe if you go to your devices, hopefully you're seeing the question on your devices in front of you. Okay, so I see some people are putting answers in there. So look, this is just a guess. The only reason I know this is because I looked it up. So just have a crack at it. All of these questions are completely anonymous. So there won't be anybody, there'll be no league table or anything like that. Okay, so it's 23 years actually. So the majority there, the joint majority, got the correct answer, and I suppose so. That's the correct answer there. So and that's where that particular figure came from. So there is a downside, of course. So in 2021, the Lancet estimated that over 1 million deaths globally were directly due to antimicrobial resistance, and antimicrobial resistance contributed to nearly 5 million deaths. Those numbers are projected to increase up to nearly 2 million deaths in 2050. All right. So some of what they do is very obvious. Back in the day, if we were chasing prey or something like this and got a scratch in the arm from a briar, if we're unlucky enough that sepsis or that cellulitis developed and that progressed to sepsis, well, that's life-threatening. So antibiotics clearly will treat infections, but if you think about it, surgery, chemotherapy, heavy-duty immunosuppressant medications, orthopedic surgery, transplant surgery, even simple things like siting an IV cannula, much, much riskier if antibiotics are not available. So really the foundation of medicine is very dependent on the availability of effective antibiotics. And of course, that's the reason why antimicrobial resistance is such a concern. So I have to make a confession now. And it is true to say, I have a particular interest in this area, but it is true to say that I have on occasion in the past prescribed an antibiotic that I think probably was not necessary, maybe for a viral illness or something like that. So it's often not a knowledge about antibiotics or about their lack of efficacy on viruses that is the reason for GPs prescribe or doctors prescribing antibiotics that may not be needed. So what I'd like you to do now with your devices is just, if you can, in one or two words, just to put in some suggestions as to why you think doctors prescribe antibiotics that they know are suspect are unlikely to be needed. So I'll give them a few. I know this takes a little bit longer than just clicking a button, but I'll give you a moment to do that. Great. Okay, so thanks very much for that. So here we go. So pressure, yeah, patient expectation to please people, yeah. There's one there, doubt. So clinical uncertainty or concern about people becoming sicker. Yeah, so just in case, yeah. So I think that they're really common explanations. And I have something here from this is from a British Journal of General Practice paper that summarizes some of the reasons why clinicians prescribe antibiotics that may not be needed. So a belief that bacterial infections always require treatment with antibiotics. Of course, even if an infection is bacterial, it doesn't automatically mean that an antibiotic is required. And I'll touch maybe on some of that later on. From the last slide, there was an acknowledgement that we respond to patients, actually I've run ahead of myself there. So we can perceive that antibiotics will expedite recovery from illness or indeed reduce complications, when in fact the risk of complications is very small, and the benefit in terms of timelines can be very short as well. There's a fear of litigation, and it's not just medical legal, it's also the clinical concerns about a clinical deterioration. And then a belief that parents or patients are seeking antibiotics. The interesting thing about that is that the literature would suggest that doctors overvalue doctors perceive that patients want antibiotics more than patients actually want antibiotics. That's what the literature says. So if it's not just knowledge, part of the solution is consultation skills. Now, I'm not going to go into detail in this. So people who are members of the Irish College of GPs will have access to a training module on this on the ICGP education platform, icgpeducation.ie. And the module is called IPC, Infection Prevention Control and Antimicrobial Prescribing. But very briefly, it's important to ask people what their concerns are, because if somebody's coming into me and they want a note for work, and they end up going out with an antibiotic that they didn't want in the first place, well, that's just not a great outcome, assuming they don't need the antibiotic. A nice trick here with H for history and examination is that and this is maybe a takeaway point because it's easily applicable in clinical practice today. So if you're examining somebody, if you give a running commentary of the normal or reassuring findings in that exam, that is very reassuring for people. So that might sound like something, you might say something like, look, heart rate is normal, the oxygen levels in the blood are fine. When I listen to your chest, it sounds okay. So that's all very reassuring, something like that. Because of the issue that was correctly identified in the word cloud slide earlier, that patient expectation drives antibiotics, it's important to find out what patients are hoping that you will do. So, for example, how do you think I could help you today? Or what do you think about antibiotics? Or even more directly, were you hoping that I might prescribe an antibiotic for you today? Just to find out what their expectations are. Because if a parent says to me, no, I prefer not to use an antibiotic, and I don't think an antibiotic is required, the rest of the consultation is going to be quite different than if the person says to me, oh, I really think he needs an antibiotic because the last time he needed an antibiotic and he got better within a few days of starting the antibiotic. Okay, so finding out the expectations helps with that. The next one, the first S, symptoms. So this, I actually don't use that much. I use it opportunistically. But if people are worried about a particular symptom, so, the phlegm is green, it means I must need an antibiotic. Well, my response to that well, look, phlegm is a normal response to infection. And actually, it helps to get that gunk up and out and out of the body. And actually, green phlegm is the norm with infection, even if it's a virus. And of course, viruses don't respond to antibiotics. Timelines is really important because I think probably doctors and patients underestimate the amount of time that it can take to recover from common infections. So cough symptoms, acute cough symptoms typically will last up to about 3 weeks. And when people are told that, they know then that if their cough is still there 2 weeks later, it doesn't mean that some terrible complication has happened. The shortcomings of antibiotics. So in the past, I've tried to get into this business of antibiotic resistance and explaining that and antibiotics not working in the future. My experience is that it simply doesn't work. This consultation model has a different approach, and it tries to focus it in on the individual in front of you in the seat. So you might say something like, well, look, the problem is this is a viral infection, and antibiotics just don't help for viruses, and they commonly cause side effects. 10 to 20% of people who take an antibiotic will get side effects: vomiting, diarrhea, thrush, allergy. And actually, what I worry about more than those side effects, although I worry about those, what I worry about more is that they can cause superbugs. So something like that. I think we all develop our little script that we can use in these circumstances. Self-care advice, so you need to tell them how to look after themselves. So whether it's Calpol or paracetamol for adults or ibuprofen or whatever is appropriate and indicated. And then we've heard so much, and rightly so, we've heard so much about sepsis recently. So safety netting advice is really important, so people know when to come back if there's a deterioration. Now, if you look at the bottom left of the slide, written vertically, you'll see covered by patient leaflet. So what we have developed is this Treat Your Respiratory Tract Infection leaflet. And it includes I'll just go back one slide. It includes the timelines, shortcomings, self-care, and safety netting elements of the consultation. That has proven to be quite popular. I was just looking at the metrics yesterday. This is the most widely downloaded form from antibioticprescribing.ie over the winter. So it's widely used. In addition, we have sent copies out to every GP in the country. We've just published a paper that looks at the feasibility of this paper, and 94% of GPs felt that the leaflet did not lengthen the consultation, and a significant minority felt that it shortened the consultation. And you can see there, over 90% of GPs found it helpful. Nearly everybody said they would use the leaflet again. And on the patient side, 88%, nearly 90% of people felt more confident in self-managing their symptoms. And it was positively received by virtually everybody. Okay, so that's the chest SSS. Maybe at this point I might just pause if there are any comments in the chat. I can't actually see them because I'm presenting, but if there's any comments there or questions from the floor, I'd be happy to take it. So if that's the case, just stick a hand up, and if not, I will keep going. Okay, move on. Now, 68-year-old lady. Now, again, these are all anonymous questions, so you're not going to be identified. 68-year-old lady presents to you with an infective exacerbation of COPD. How long would you treat for? 3 days, 5 days, 7 days, 10 days, 14 days? I suppose I should just caveat this, that this is relevant for general practice. So probably also applicable to the emergency department, arguably, and probably outpatients as well. Okay, great. Plenty of answers coming in there. Thanks for that. So we'll just go on. So 5 days is the right answer. So what we're saying is strive for 5. Okay. So for all respiratory presentations where an antibiotic is indicated, 5 days treatment is what's recommended. So traditionally, it was probably a 1 or 2 week course. And Lou Rice, who's an American, in this paper cited at the bottom, said that the durations of antibiotic therapies are often a week to 2 weeks because there's it's often 7 to 14 days because of 7 days in a week. And that it was the Roman Emperor Constantine the Great who decided that there should be 7 days in a week. And had he chosen a different number of days in the week, we probably would prescribe antibiotics differently. The problem is that the Roman Emperor Constantine the Great was probably pretty good at being an emperor, but not so good at evidence-based medicine. So I'll just quickly show you these. Are we for time? We're okay for time. So for community-acquired pneumonia, 5 days treatment is recommended. For acute bacterial sinusitis, where you decide to treat with an antibiotic, 5 days treatment is recommended. In fact, acute bacterial sinusitis will get better without antibiotics in the vast majority of cases, and the difference that antibiotics make is very small. It's less than a day. Infective exacerbations of COPD, 5 days. Pharyngitis, sore throat, tonsillitis, 5 days. So the key thing there is strive for 5. If you are going to prescribe an antibiotic for respiratory indication, 5 days is the recommended duration according to national guidelines. So strive for 5. What I used to do I've run this face-to-face in a number of places, and I used to ask the audience to stand up and give me a virtual high five, because it's kind of an awkward thing to do at a conference, and that awkwardness or emotion, I think, helps people to sometimes remember, perhaps in a traumatic way, I don't know, but certainly that's what I used to do. I've stopped doing that because I had a bit of a worry that it would look like a Munich salute, which is very unpalatable. So an awkward high five like this is another option. So strive for 5. Okay. Here's a nice tool which is derived in general practice in the UK. So this is based on a presenting cohort of people with sore throats who go to GPs in the UK. I think in the interest of time, I'm not going to go into it in detail, but it tells you when an antibiotic is more likely to help. It doesn't mean that every sore throat with a high score has to have an antibiotic. It just means that an antibiotic is more likely to help. And there is a version called the Centaur score, which can include the Mac-Isaac modifier, which is based on a US population presenting to the emergency department. And again, it just helps to work out when antibiotics are more likely to help. So most sore throats do not require an antibiotic. And sometimes because of, if you use the Centaur criteria or the fever pain score, you can work out which people are unlikely to benefit from antibiotics. And pain relief for everybody. But if you're really feeling under pressure with a sore throat and you know that an antibiotic won't help, the BMJ have made a rapid recommendation in relation to the use of steroids for sore throat. So for sore throats that clinically are viral, and where analgesia has not been effective, there can be a role for steroids. So a stat dose of dexamethasone 10 milligrams or 0.6 milligrams per kilogram for children, and that's based on a 2017 recommendation. Now, this does not mean that everybody with a sore throat needs steroids. It's just that rather than going down the route of antibiotics, which you know are going to be ineffective, that you have somewhere else to go. I suppose it's a response to dealing with that perceived pressure, or indeed that actual pressure that sometimes happens when people are feeling very miserable with a sore throat and they just want to get better.
Scott, there's a question here just before you move on there. Can I ask, do you think antibiotic therapy for chest infections is more effective in children than in adults?
Okay, so it really, thanks Michelle for that, and thanks to the questioner. It really depends on the effectiveness depends on the diagnosis. So the national guidelines on antibiotic prescribing.ie, if you have a look at them, for acute cough, antibiotics are not recommended at all. Okay, so antibiotics make almost no difference to acute cough unless it is a community-acquired pneumonia or an infective exacerbation of COPD. So the vast majority of coughs are viral, and those that aren't, at least in general practice, the vast majority of them will settle down themselves. And that's for adults and for children. I suppose in adults, they're more likely to have a diagnosis like an infective exacerbation of COPD. Now, of course, there are more complex situations like people with CF, or there are other situations. But in the round, antibiotics make make almost no difference to acute cough. And that's why the national guidelines no longer recommend antibiotics for acute cough unless there is a specific indication like community-acquired pneumonia. So I hope that answers that question.
Yeah, that's from Elaine.
And any other questions, Michelle, in the chat there?
Nothing so far. Does anyone want to put forward one while we have a little break? Are we okay? I don't see anyone putting a hand up or anything, so we can continue.
Carry on. Okay. Acute otitis media. So acute otitis media will get better with or without antibiotics, even if they're bacterial. So consider no antibiotics are a backup prescription to be used, for example, if there's no improvement in 3 days, or just analgesia. So the people that are most likely to benefit from antibiotics in acute otitis media will be children under 2 with bilateral acute otitis media. It doesn't mean they have to have an antibiotic, but they're more likely to benefit. The other group is people with otorrhea. So if they have pus coming out of their ear, an antibiotic certainly is reasonable then. Okay. There are circumstances if people have, now acute otitis media is almost exclusively in children. So if people have underlying immunosuppression or if they've comorbidity, of course you'd be faster to use an antibiotic in those circumstances. But in the round, acute otitis media will settle down absolutely fine without antibiotics. And the use of antibiotics on average reduces the duration of pain and fever by about 1 day. Little bit less than 1 day. So paracetamol and ibuprofen, of course, will treat pain as well. And it will do so without the side effects associated with antibiotics for the most part. Okay. Acute sinusitis. So acute sinusitis, now sinusitis is an interesting diagnosis because it suffers from a labeling phenomenon. What it means is that, let's say for whatever reason, I decide that somebody who comes into me, I'm going to give them an antibiotic for their head cold. Now, I know that coryza or the common cold or a head cold is not going to benefit from an antibiotic. And it really doesn't make a whole lot of sense to prescribe an antibiotic for a diagnosis of a head cold. So what tends to happen is that people are driven to diagnose the condition as acute sinusitis and to issue a prescription for an antibiotic. But even if it is acute bacterial sinusitis, antibiotics make very little difference. They reduce the duration of symptoms by around about a day. However, what can work, what does help people with their symptoms, is the use of intranasal steroids at a high dose. So that's something like triamcinolone nasal spray, which is called Nasonex. At a high dose will be 4 sprays into each nostril once daily. So there's some evidence supporting that. And of course, if we do that, it means we avoid antibiotics. Sorry, Michelle, I saw you unmuting there. Is there
There's another question actually on the kind of steroid piece, Scott. So it's from Anna, and she wants to ask about your opinion on steroids. From my humble observation in Ireland, steroids have been prescribed more often for viral infections than other countries. For example, Malta, where I've been practicing before coming to Ireland, 3 years ago, the indication for steroids were exacerbation of COPD, asthma with confirmed COPD with confirmed LRTI and croup. What do you think of about abuse of prescribing of steroids, especially in the pediatric population?
Yeah, well, I mean, I think the use of, so you might have noticed I caveated my comments about the use of dexamethasone in sore throat for a very particular group of people when all else fails. So I completely agree that steroids should be minimized. I'm afraid I don't know the data about the prescribing rates in Ireland compared to other countries. I do have the sense, sort of anecdotally, that they're used regularly. And of course, there's risks with everything we do in medicine. There's risks with getting into a car. So there's risks with everything, and including risks with steroids. And I agree with the sentiment of the question of trying to minimize the use of steroids for sure.
I think, we talked about patient expectations, and there's another comment here that someone else who's come to Ireland to work here but find that steroids are a handy alternative to antibiotics in kids with a chest infection when the parents are putting the pressure on, like you're not going to give them anything.
Yeah.
Yeah.
So yes, but that also is not without risk. My suggestion for that would be to try the CHEST SSS acronym. So for GP, if that's from a GP, if that comment is from a GP or a trainee with the Irish College of GPs, there is access to a training program on the icgpeducation.ie website. But for those who don't have access to that, if you look at target antibiotics, if you Google target antibiotics, you will find an open access course which we used with permission to produce the Irish College of GPs iteration. So the CHEST SSS consultation skills model is a really effective way at reducing antibiotic consumption whilst maintaining patient satisfaction. That particular model was assessed in a 2x2 factorial randomized control trial in the south of England, and the findings were that it was effective and acceptable to patients. So rather than steroids, look, if you must, fair enough, but I would suggest the CHEST SSS consultation model. Thanks. Anything else, Michelle, or will I go on?
No, we just popped up that link in the chat as well if anyone wants to look at that from the RCGP. Yeah.
Thank you. Yeah, the antibiotic toolkit, that's what it's called. Yeah. Okay. Right, so that's respiratory hacks. Bite-sized dental nuggets. Here we go. So the dentist told me to come to you. So a fit 22-year-old, no past history. He has bad pain in his mouth, initially only when eating, that started yesterday, but it's been getting worse. And last night he couldn't sleep and he's really sore. Like there is dental pain is a particularly unpleasant type of presentation. And the dentist told him to come to me. Now, probably it was the dentist's receptionist that told him to come to me. That's actually probably what happened. But anyway, type the name of 1, 2, or 3 drugs that you might consider prescribing here. And again, you're amongst friends. This is all anonymous. Great, thank you. We have our first response, and there's a few more coming in there, which is great. Lovely. I see. I was able to access the chat there, and I see some Flagyl is mentioned, and penicillin V, or Calvapen is the brand name, or Copen is another brand name. Okay, that's great. So I'll just show those responses. So metronidazole, nonsteroidal pain relief, and various antibiotics. Okay, great. So I think what I'm going to show you now, I hope might be practice changing. So antibiotics are indicated in certain situations for acute dental pain. So if there's dental pain and swelling and any one or more of the following: cellulitis, well, really you're treating the cellulitis more so than the dental pain, tender lymphadenopathy, trismus or difficulty opening the mouth, or a fever. So if they are the 4 indications for antibiotics when somebody has acute dental pain with some swelling. And if they don't have any of those 4, then what they need is 2 things from you, from the doctor. They need pain relief and they need a dentist. So we've talked about Strive for 5. The next soundbite I want to give you is procedures, not prescriptions, fix dental pain. Okay. And this is what the guidelines say. And there are guidelines published in the dental section of antibioticprescribing.ie if you want to have a look at a little bit more detail in that. So pain relief, and tell them, look, you need to go to a dentist. The problem, of course, is that it's really difficult to access dental care. But you as a doctor are not going to fix the underlying cause of their dental pain. It has to be a dentist. Now, this is hen's teeth, really rare stuff, but just to mention it, occasionally, I've never seen this, but an emergency referral with acute dental pain is indicated if there's airway compromise, if there's rapidly spreading infection, if there's suspected sepsis. But this is really, really rare in clinical practice. Okay, so that's bite-sized dental nuggets. So the takeaway point I would suggest is procedures, not prescriptions, fix acute dental pain. Okay. If there's anything there, Michelle, in the chat, just give me a shout. Otherwise, I'll keep going to urinary stream of consciousness. Okay. Sorry, Michelle, go ahead.
No, it's all fine. It was
okay.
just a few late joiners. I just republished the bits if people want to join on or put their buddy points in. That's all. Keep going there.
Thank you. So here's a few questions for the audience. So dipstick urinalysis is helpful in diagnosing UTIs in pregnancy. True or false? Give you a few minutes. And for people that have maybe just more recently joined, it's maybe worth just saying that all of the answers here are anonymous. Nobody's going to be identified, and there's no league table of who did well or otherwise at the end. So dipstick urinalysis is helpful in diagnosing UTIs in pregnancy. So I'll just show you the answer to that. The answer is false. Great. So lots of people know about this. Okay. Next one. Dipstick urinalysis is helpful in diagnosing urinary tract infections in patients over the age of 65. Okay, so again, in the interest of time, I'll keep going. So again, great, false. So the incidence of false positives in people over 65 is really high. Now, there can be very good reason to do a dipstick urinalysis in somebody over 65. It's just, and indeed in pregnancy, but diagnosing a UTI is not one of those reasons. And the reason is, what happens is you get a false positive, and that drives us then to prescribe antibiotics. And number one, it's not going to work because it's the incorrect diagnosis. Number two, it exposes them to antimicrobial resistance. Number three, it creates doctor dependence because they'll come in and want the urine rechecked again. And of course, number four, whatever the actual underlying diagnosis is, well, that's not being addressed. Okay. Here we are. Dipstick urinalysis is helpful in diagnosing UTIs in catheterized patients. True or false? You've kind of identified a theme here, I think. Okay. What? Yes, okay. That is the correct answer because of false positives. Okay. Now, an extra option here. Dipstick urinalysis is helpful in diagnosing urinary tract infections in males under the age of 65. Yes, no, maybe. Okay, let's see what you thought. Yeah, so this is just a little bit trickier. Really, for men with suspected UTIs, well, first of all, we need to think about sexually transmitted infections. Ideally, we should be sending the samples to the lab. I know there's some microbiologists on there. I hope I'm not going to get myself in trouble with the microbiologists. But the recommendation for men under 65 with symptoms suggestive of a UTI, we really should be doing absolutely everything we can to get a sample to the lab. The problem is, certainly in general practice on a wet Friday evening at the end of January, is that sometimes you just can't get the sample to the lab, and you have to work with something. So sometimes dipstick urinalysis can be helpful as an interim measure to help you decide if you should treat with antibiotics at a time when you're unable to get a sample to the lab. Okay. So maybe. Dipstick urinalysis is helpful in diagnosing UTIs in non-pregnant females under the age of 65. True or false? Okay, so let's have a look here. So actually, I think I was leading you up the garden path a little bit with the series of questions. Hallelujah, dipstick urinalysis has some utility, and its usefulness is in the context of female patients who are not pregnant under the age of 65. So if there are findings suggestive of a UTI, that's predominantly pus and nitrites, and the clinical picture fits, well, then it is reasonable it's appropriate to treat them for the UTI, and generally it's not necessary to send a sample to the lab in that situation unless there was previous resistance or a lack of response to initial treatment or something like that.
There's a question here, Scott. Would you wait for the culture results or treat while awaiting results?
Is this for the men? Well,
specify, but I suppose yeah.
So, for the non-pregnant female under 65, treat on the basis of a clinical diagnosis, and the dipstick urinalysis will support the diagnosis. In men, like urinary tract infections are much less common in men. But I think really that depends on the clinical situation. If you're suspicious for a sexually transmitted infection, well, there's really not much point in using nitrofurantoin. If they're sick with something like acute prostatitis, they need treatment the same day. They can really get quite sick with that. So it really does depend on the clinical context. And I'm sorry to the person who answered the question. I'm not trying to avoid the question, but I just don't think there's one single answer to that.
And there's another comment about the potential of samples to be contaminated if they're dipsticked by the time they get to the lab.
Well, I mean, that's potentially an issue. Dipsticks are usually kept reasonably clean, but of course, contamination is a possibility. What the current practice is to decant or to put the urine sample into a tube, a closed tube, and send that to the lab. And that can be done before doing the dipstick test. So that's a kind of a workaround there. Yep.
And there's another question about in patients with older residents in a nursing home. I suspect you have dementia. We are now told to dip the dipstick and only treat if the residents are symptomatic. What do you think?
So this is a really difficult area. Because it's difficult, we have produced some guidelines which are available on antibioticprescribing.ie. So there's a position statement and there's an algorithm. I'm afraid I can't remember the precise name of the document. But if there's a few minutes at the end, what I'll do is I'll dig that out.
That while you're going there, yeah. No,
it does. I think it's under the urinary section, but it might be under a section on residential care facilities either. So this is really difficult, particularly if somebody is delirious or if there's a kind of a general deterioration. It's a difficult area, but there's good guidance available, and it's also worth thinking about non-UTI causes of a deterioration. And there's a nice little acronym which is called Pinch Me that is in that guidance document. I think I probably won't go into that in detail just now, just because of time, but there is guidance on that. I think the questioner is absolutely right that this is an area that is difficult. This is why they pay you the big bucks, guys. Okay, so in relation to urinalysis, what we say is skip the dip. Okay, so we have strive for 5. We have procedures, not prescriptions, fix acute dental pain, and skip the dip. But also to acknowledge that dipsticks do have utility in the diagnosis of UTIs in non-pregnant females under the age of 65. Okay, how are we for time? Okay, very briefly, backup prescriptions. So backup is a slightly better term than deferred prescriptions. But I'll just say there is evidence supporting the use of backup antibiotics. And for respiratory indications, only about a third of people in this study had the antibiotic dispensed when a backup prescription was provided. For UTIs, the most deferred antibiotics or most backup antibiotics end up getting used. But for respiratory symptoms, it can substantially reduce antibiotic consumption. Okay. Yeah, okay. So I'm not going to go into that just because of time. I'm conscious that we're coming close to the end. Okay, here we are. So this is the really hard quiz now. So what I'd like you to do is, if you don't mind, is to write in 1 or 2 little bullet points of things that you have learned today that maybe you'll be able to use in clinical practice today, tomorrow, next week, or maybe after a little bit of reading later on. I think if you make those things explicit, if you state them, there's just a higher chance that you'll recall them and hopefully use them. I have to say, I'm delighted with the level of engagement. So thank you very much for your contributions. It's greatly appreciated. Okay, we've 10 responses. I'll just show the responses and see. Strive for 5. I was hoping that would come up. Skip the dip. I was hoping that would come up. Chest SSS, great. The chest SSS, I think, like lots of skills, that's the kind of thing that needs a little bit of practice. Give it a try. Hopefully you'll remember maybe 1 or 2 points from it. But if not, there's resources available, which and thanks to Michelle for posting those into the chat. No antibiotics for ear infection. Yeah, great. No. So I just see no skip the dip for UTI in pregnancy. Now, of course, dipsticks are helpful to identify to help identify preeclampsia, but specifically with regard to a urinary tract infection, dipsticks are not helpful. Strive for 5, great. Procedures, not prescriptions, fix acute dental pain. Great. All right, that's great. I think I'm probably done there. Let me see. Okay, so strive for 5, you got that. Procedures not prescribed, that was mentioned. Skip the dip was mentioned. Consider backup prescriptions and consider learning and practicing chest SSS. So this is where I get all evangelical. So there may be people that are struggling for topics for a presentation in the hospital grand rounds or something like that. If any of you have an interest in this area, and probably more important, if any of you don't have an interest in this area, maybe you might consider whether some of the topics that I've touched on today might be of interest to your colleagues in hospital medicine. Now, Michelle, I think I'm nearly done there. Yeah. So I want to thank the Reach Network. My colleague and close friend, Paul Ryan, a GP down in Cork, I've used some of his material here. And Target UK very kindly allowed us to use a lot of their material in the work that we've done for the guidelines in Ireland. So thank you very much. I'll stop my screen sharing now.
Brilliant. Thanks so much, Scott. That was really useful. And as a hospital physician as well, I think we get carried away with antibiotics. It's really good to have a refresher like that. I think Anna Ruda, you have your hand up. Do you want to answer your question?
Hi, how are you? Thanks, Scott. It was really interesting. Can you hear me? Oh, yeah. No, it was very interesting, actually, and it's good to hear someone preaching in the desert, the same that we are preaching here in the hospital. And yeah, absolutely. I think it's a great topic for grand rounds. Actually, we have done it a few times. So maybe you want to come and support us from the other side of the hospital doors. And I was pointing out at the fact of the contaminated samples for urine, because it's very, very typical to get those contaminated samples, and it's really sad when you see it at the lab because you can't read, you don't know what you're looking at actually. So, and it's and the advice we are trying to avoid the use of dipsticks in the hospital, because basically what the recommendation is to treat a UTI because of the symptoms. So you decide that it's a UTI or not based on the symptoms, not on the dipstick, in most patients. So, and I think dipsticks are very useful for ketones, albumin, proteins in pregnancy, but the rest is not. You need to look after the symptoms, and then you decide if it's a UTI or not. And many times we have seen very poor practice in the hospital. I'm not saying anywhere else, in the hospital, with people doing the dipstick, and then that same sample that is left is sent to the lab, so it's all contaminated. So that's why we are encouraging not to use the dipsticks.
Thanks. Rob, do you mind if I just jump in there?
Yeah, please, Scott. Yeah, I just have a question. Yeah.
Yeah. Okay. Great. So the skip the dip. I'm glad to hear that that's a priority in the hospital as well. So maybe if there are people in other hospitals outside of Sligo, Anna, of course, is a consultant microbiologist in Sligo University Hospital. So if there are people in other hospitals as well, maybe that's an easy win for a topic for grand rounds. In Ireland, we're oh God, I just can't remember. I think it's the ninth highest prescriber of antibiotics in the community out of the EU 27. So it's not great, and we'd like to be down closer to where places like the Netherlands and Denmark and Estonia are. One thing that we are really, really good at is we are one of the lowest in Europe at prescribing fluoroquinolone antibiotics. Okay. Now, the thing about fluoroquinolones is that they seem to dissolve the glue or the connective tissue that holds bits of us together. So they will increase the risk of abdominal aortic aneurysm rupture. They will increase the risk of tendon rupture. And also they tend to make our retinae fall off the back of our eyes as well. It increases the risk of retinal detachments. So we're really good at avoiding ciprofloxacin and other fluoroquinolone antibiotics. So it's not all bad, but certainly we still have plenty of work to do. Thank you. Sorry, Rob.
Yeah, thanks, Scott. Thanks for your presentation. Lots of useful information. I just had a question from a kind of a rural GP perspective. In the rare occasions that we are going to send a sample of urine to the laboratory, is there any recommendation on how long we can delay that? So that Friday evening scenario, in my kind of GP mind, sometimes I have taken a sample as sterile as possible and maybe sent it on Monday morning. Is that a big no-no, or do you have any thoughts on that?
Do you know what I'd like to do maybe is see if there's anybody that I don't know is what I'm trying to say, but I'm trying to dodge it by seeing if anybody else online might have an answer for that.
To my simple, before there's an answer to, but to my simple way, like if we are going to grow something, it's sitting in our surgeries, as long as it's obtained in as sterile a way as possible, it shouldn't do any harm, but I could be wrong on that.
There's another comment here about the possibility of urine samples being clotted now. I haven't heard that. I've heard of them being contaminated, but maybe some of the microbiologists might tell us about that. But
sorry, I was muted. Now the recommendation is to keep it no longer than 24 hours, and ideally those 24 hours it should be a urine sample should be in the fridge. Should be refrigerated, because what we are trying to do is to delay the growth of any contaminants. So, and unfortunately, yes, I was a GP for a few years before being a microbiologist, and I have been there. I know the complication of sending samples on Fridays. All I can say is the lab is open on weekends, and we can take the samples in. So we can keep them. Or even if it's an emergency, you can give us a call and we can try to plate it and process it but don't tell anyone. Don't let the lab staff know that I said this. But we could arrange if it's a special case and we need a culture. It's important, the culture.
Thank you. We'll edit that out of the recording.
Okay, please.
I think Jennifer Carroll McNeil might back you up there on the old 7/7 working, so we might get you might get a bit of funding for more lab staff. The other question in the chat here is around CRP express testing in primary care, and it's used widely in the Netherlands. Anyone experiencing that, or Scott, do you want to come in there?
Okay, so the HIQA have done a health technology assessment looking at near patient testing, and they have concluded that it's not cost effective. I think whilst it certainly has some utility, there are very significant kind of structural and support issues that need to be worked out before that would become a reality. So I think there's potential there, but we're not there yet in Ireland. There are other near patient testing as well, group A strep and COVID and flu and stuff like that, but we're not there yet.
Okay. In the interest of time, is there any other questions or comments? I think we've tried to keep up with most of the stuff in the chat, and I see that Skip the Dip has been promoted in Roscommon and Port Jimcla. I must get on to our own grand rounds, people in UHG, Scott. You might get another job, but I think it'd be a very useful session. Maureen, sorry, I see your hand
Just
up
one
there.
last closing comment for Scott's opinion on. Sometimes I think the virus versus bacteria debate, the conversation that we have with patients in general practice has almost led to an expectation that if we think it's bacterial, they must have an antibiotic. And I wonder, have you got an answer for that in your script that you use with patients?
Yeah, first of all, if I just take a step back from that, I think when I'm making decisions about whether to prescribe an antibiotic, I do that on a clinical basis, which will include things like, frailty, comorbidities, background of diabetes, underlying immunosuppressive therapy or illness-causing immunosuppression. So they're the kind of things that I think about, and I'll decide if I want to prescribe an antibiotic or not, and then I prescribe the antibiotic or not. I don't really get into if I think it's viral and it doesn't need an antibiotic, I'll do my whole spiel about that. But I haven't really gotten into this discussion about, well, it's bacteria, therefore it has to have an antibiotic. I kind of just don't really get into it, I think. It hasn't arisen.
Okay.
Can I ask Scott, and you may know this, but is there any evidence, the online consultations that people can do with the GPs online? And I wonder, is there any evidence that there's more antibiotics prescribed there, or does that impact on our resistance at all?
Yeah, I don't think we've data on that, but anecdotally, it's certainly a concern. I have a graduate of our practice. He was a reg with me. He has come back to me and said, "Listen, you need to do something about the online prescribing." He's working in that space. I think some of the providers are very carefully audit the antibiotic prescribing that goes on. I think others less so. That is something that has piqued the attention of HSE AMRIC. That's on the radar. Yeah.
Yeah. Certainly, anecdotally, you hear of these, and I think as well it kind of highlights some of the problems with maybe rural practices or practices that are oversubscribed, that people feel they can't get an appointment and they might go online then as an alternative, and how that might follow out.
I mean, it's worth saying, like, it is really difficult to assess people over the phone. You can't access the 6 vital signs. So I can see why doctors working in that context with the best will in the world would be pushed towards prescribing an antibiotic. I see there was a comment there in the chat about out of hours, and the out of hours is similar. Working now, this is different maybe in hospital medicine or in a lot of hospital specialties, but like in general practice, we will usually know our patients really well, and we'll know the people. I've had 2 people that have come to me who I've suspect. Sorry about the balloons. I don't know how that happened. So I've had 2 people that have come to me who I've diagnosed or been very suspicious of Addison's, and they subsequently got a diagnosis of Addison's, not because of classic symptoms, but because they don't come very often, and they come complaining of non-specific fatigue and things like that. And what made me think of it was, this is really unusual for this particular person to come complaining like this. So similarly, when it comes to antibiotics, we know our patients in general practice. We know if we'll have a sense of whether we can trust them to return to us if there's a deterioration. You lose an awful lot of that in the out of hours setting.
And I think there's a comment here about Comaxlab maybe being used as a bit of a sledgehammer to treat all ills in the out of hours prescribing particularly.
Yeah, I think that sometimes happens where there's a general deterioration. You're thinking, God, is this urinary? Is this respiratory? That sometimes happens. But I think the bigger picture with Comoxiclav is that it's a habit. Our Comoxiclav prescribing has really fallen nationally, so we're making progress on that. And over 80%. The other thing we're good at in Ireland is we are very good at prescribing narrow spectrum antibiotics compared to the rest of Europe. So we're good at that. We need to get the overall consumption down, though.
Yeah, absolutely. I suppose on that positive note, we better end because Robert Scully will kill me. All the other sessions have been right on time, so we're about 2 minutes over, but I think it was really valuable discussion. So thank you very much. And thank you, Paddy Barron. I see the National Shared Care Record will be a game changer for being able to look at some of this stuff, and the electronic health record. So thanks again to Scott for such a wonderful presentation. Really practical, really useful to everyone involved here.